All right. Wow, what a great group. Look at that. It was actually very interesting to me to hear this last presentation because I'm also part of the Health and Human Services Region 10 emergency response team, and I'm on a cadre of officers and other folks in Health and Human Services out of Seattle that would be the first responders if a surge from the federal side related to health would be required. So that's another arm of what I do. So one thing I didn't figure out is how to advance. Okay, forward back there. Just here. Okay, great. Thank you. So I'm here to share a little bit about my experience. I know Ebola now is a year old. It's probably been beaten into everybody's heads, so I will keep that in mind. And really what I want you to think about is when I say the word Ebola, think more broadly: infectious disease, mass public health issues, communicable diseases, all those things that relate to bacteria and viruses and those things in the environment, populations, and cause a lot of illness. So yeah, please keep that in mind. So what I'm here to do today is I am in uniform. I'm not here to deliver any official Health and Human Services messages. I'm here to tell my personal story and share with what I know. So there's my disclaimer. All right, so what I want to do is, as I said, but also I want to segue into updating on the global movement to preparedness and some of the lessons learned and some of the things that are changing and some of the thought processes that are shifting. And then hopefully we'll hear a little more about the regional side and drill it down to our area. So the U.S. Public Health Service, just in case you're wondering why I'm standing here looking like I'm from the Navy, because I do have a few Navy ribbons on here. We are a uniform service comprised of 6,800 officers under the direction of the U.S. Surgeon General. And as you may know, we have a new Surgeon General in place and comprised of these professions that you can see on the screen. And then the mission of the Public Health Service Commission Corps, one of the 7 uniformed services, is to protect, promote, and advance the health and safety of the nation. Public health needs, of course, leadership and excellence in public health practices and advancement of such as through NIH or the Centers for Disease Control. So on the Ebola response, it was, as you know, the largest response in history, starting in West Africa, unprecedented outbreak, and we recognize that the only way to eradicate the threat in America, a national security priority, was to really defeat it at its source. That's an important thing to keep in mind. We have a history of thinking things are over there, and as we become more global, those thought processes have to shift. So the U.S. strategy in the response to the Ebola epidemic was controlling the epidemic, as I said, at its source, mitigating second-order impacts, as you can see on the list there, and engaging and coordinating with a broader global audience and beyond. And I'm going to go through these a little bit faster as I cut down my presentation, but I'm hoping that this may be available to you later, so I packed it in this presentation a little more than I will present. So back in October, we got a call from the Office of the Surgeon General, and they had decided which 65 officers were going to be selected to be on the first wave of response. And there I was on my way to Alabama to get 7 days of debrief on Ebola, and I didn't even know how to spell it when I first heard of it. So that's how much I knew about it. And then I was on my way over to work in the response. So a total of 4 teams have been deployed since October, and each deployed team was about 2 months. So I worked from October through December. Now that medical Monrovia unit that is over there is now operated by the Liberian government. So why did we go? So our mission was to provide hope through care to healthcare workers in Liberia who may have the Ebola virus disease, and to continue efforts with the Liberian and international partners to build capacity for additional care. If you think about it, what would have happened if nobody in the rest of the world responded? What would have happened to that outbreak and to those affected and the spread of that disease? So it took the global community to really respond, and the United States made the decision to send a team to actually be those helping prepare or provide care, and our mission was to support the healthcare providers. The thought was that those healthcare providers that were responding and volunteering to go to Liberia knew they had a place to go for care, then maybe they would be more confident in taking that charge and going over there and helping out. So it was a 25-bed hospital specifically designed to treat infected healthcare workers, like I said, and really also work with those that may be symptomatic. So when we arrived there, this was next to the airport. The Seabees from the Navy set up the tents, the brown ones that you see on the slide. There was nothing else there when we arrived. None of that other infrastructure existed. This is a Team 4 shot. So here we are arriving at these tents with a cache for a triage unit from the Army, boxes of supplies, and we're supposed to take this Army hospital and transform it into an Ebola treatment unit. None of us on our team have done that before. None of us had really partnered with entities like the non-governmental organizations and other military folks. So there was a really quick, long learning. So here's our team, 65 U.S. Public Health Service officers, doing everything, as you know, in the emergency response structure, the planning, the logistics, the administration, the healthcare providers there, and this was basically the entire team that it took to operate a Ebola treatment unit or a field hospital. I'll just leave this in here. You can, if you want to see a tour of the hospital, there's the link for it. I won't go into it. I'm not going to go into a lot of the clinical manifestations that are listed here, but one of the things that I wanted to bring out was that on the bottom there, you see the possible infectious causes of symptoms. So if you think about patients coming in, you don't really have your lab capability set up. We had a lab, but we didn't have reagents yet, so figure that out. But you come in with a fever. What disease do they have? What do you treat? Do you treat for malaria? Do you treat for Ebola? And you have to make all those decisions. None of us had been prepared to really work in a place where there was a 50 to 70% fatality rate. Imagine working in that environment. So that was another challenge to overcome. And if you see on the left side, the organ systems, so you have patients, and these are the organ systems that are affected from Ebola or impacted from Ebola. And so you have all these organ failure types of things to deal with, and you have very minimal supplies. You can rehydrate, and the rest of it is hoping nature is stronger than the disease or the virus. So here's some of the examples of the hemorrhagic signs. And the laboratory findings for those clinicians, this is just some of the things that we monitored and worked with. One of the things that came up really quickly is the renal failure in patients due to dehydration. And we had, for those that know, the creatinine level normal is, I think, 0.6 to 1.2. And we were getting patients with 12, a creatinine level of 12. And believe it or not, they walked out of that hospital cured of overcoming Ebola, of course, needing dialysis later. So we worked on case identification, treatment, and our goal was that those healthcare providers would be able to return to the healthcare workforce. that's why we were there. So what were some of the challenges? I know I'm going through this really quickly, but I have something more important to say a little bit later. Is that it had never been done before. The U.S. government had never sent out a group of folks to actually provide on-the-ground care. It was difficult to diagnose without the lab results, like I've said, and there was a lack of a ready supply stream. We were down to needing duct tape for lots of things that you'd never think you'd use duct tape for. And we were learning a lot from the other response partners that were in the country and how to work with them. So we actually did send out providers to other operating Ebola treatment centers to really get a practice on how country. We brought the lessons learned back. We evolved that into the extra capabilities that we had and moved from there. But we also had the challenge of adjusting medical standards, which that it's difficult to do, especially from our perspective in this country. We have these really high standards, but if you don't have certain supplies or if you don't have certain infrastructures, you got to make adjustments. Should I keep going? No, I'm back on. All right. So that was one thing that was a really big deal, was having those meetings with the provider teams and figuring out our level of care, our capacity, and also maintaining safety to all the staff that were there. So a lot of innovation was required. What we have here on the left side is one of our officers. We're decontaminating those that are coming out of the unit with a chlorine spray. We needed squeegees to clean the floor off, so all the fumes from the chlorine water wasn't affecting us, and that we were getting it out of our way and lowering the amount of vapors in the tents. So we built our own squeegee out of Sam's splint and an eraser board holder and duct tape and a mop handle, and that's how we were these high affluent U.S. Public Health Service officers coming over from the richest country in the world, and this is what we were reduced to. But glad to do it. What was life like? I spent 2 months, my teammates spent 2 months working day after day. We wake up an hour. We'd wake up and we have an hour commute to the hospital because there was no housing available. So if you think about all this infrastructure talk we had earlier about assuming things are going to be available, believe me, things happen, like no place to stay. So we're an hour away, so we commute an hour, and then we have a 12-hour shift, and then we have shift turnover. So now you're into hour 14, and then you go back to your lodging, and you have 5 hours of sleep, and you get up and do it over again for 2 months. When we finally got at the hospital, we were so elated, and then we were 18 guys in a tent. So what did I do? I was on the logistics team. So I worked in supply, and I helped make sure that the medical teams, those that were going into the ward, had what they needed to be safe and also to provide the care. By the end of my 2 months, you can see on the list what else I did. So you really end up multitasking. You pitch in wherever you can, and there are no job titles. So there I am. I help people get their PPE on, their personal protective gear, and I help during the time in the ward, and then I help get them out of it. What do you think the most critical point is in terms of this whole process of going into an Ebola treatment center to provide care? What do you think your most danger is in terms of getting sick yourself? Exactly, very good. Taking off the gear is where most healthcare providers ended up getting infected. So you think I had an important job? Think I was a little nervous? Of course, of course. So this is the decontamination ward, and I do have a video that's available, and it's in the PowerPoint, so you can actually just go on YouTube and watch that at your leisure. But imagine in 6 weeks of time that we saw patients using 1,000 pounds of chlorine. That's a lot of chlorine. This wouldn't fly in Spokane or Seattle, but we just burned everything in the backyard. So everything that was in the hot zone, literally everything. So how do we protect ourselves? This is the donning and the doffing of the personal protective equipment. There's the link to that, and so that can be available for later. I was going to also do a little bit of show and tell, but I will forego that. But actually, I am able to work with a patient with Ebola from this bag right here. So if you think about all the preparedness we talk about, all the stuff we think we need, the plans that we have, all the things that we think we need to stash away, this is all I need to be right next to and touching a patient with Ebola. This is my PPE right here. The problem is I haven't figured out how to get out of it. And we talked about it being the most critical thing. So I will be standing out in the field roasting under the sun trying to get all the viruses off. But this is really as simple as it can be. So don't make it more complicated than it has to be. That's my point when you think about things. So what were our outcomes? We sent 65 clinicians, administrators, and support staff to assist in the response effort. Healthcare providers in Liberia, not just Liberians, but across the globe, had a place to go if they contracted the virus. And the efforts of the U.S. Agency for International Development, Defense, the Public Health Service, the governments of the Western African countries, other partners, non-governmental organizations together built a capacity for additional care in Liberia. It was a lot of work. It was a lot of commitment. There was danger. But, you know, regardless of how many patients we saw or how many survived, I think the thing I'm most proud of is that by the time we left, we heard that there were 100 healthcare providers just from Africa that had entered and committed to be in the response to fight the Ebola outbreak. And I think that in itself made it all worth it. So we returned safely. Here I am with the Assistant Secretary for Health and Human Services. So I'd like to now move into the global movement of preparedness and just talk quickly about some of the lessons learned. So some of the things that were made very evident was that countries with weak health systems and few basic public health infrastructures cannot withstand sudden shocks to their society. But yet, as we've learned, we can be globally impacted. And preparedness also needs a swift action, and that swift action can make the difference. And no single control intervention is sufficient. So as you do your planning, think as broadly, as horizontally as you can, and make sure that all those pieces will work to the best capacity possible, because there's just not one way to fix this. Public health is so multifaceted and so complicated, and there's so many variables that we just need to really be vigilant and continue to be good thinkers about this planning effort and the surge capacity. And community engagement is the linchpin for success in controlling epidemics. And so I'm really glad that there's this local healthcare coalition, because without the community, you know, it's just not going to work. Some more lessons learned were operations. Make sure, and I'm just speaking globally here, that the needs of the patients and the communities are at the core of any response. I know there's lots of governmental and agency turfs, there's politics, there's resource issues, but really it comes down to the patients and the needs of the community. And if we keep our focus there, then our plans and our responses will be more effective. And governance and accountability, a fast response will not happen without leadership. So we need to make sure that leadership at all levels is vigilant, and that the priorities are set based on what is needed on the ground, not who's in charge or who has the most power, but really what are those needs on the ground. And with research and development, we need to strengthen research and development systems that are focused on outcomes for the global public good. A lot of what we do may be centric to the United States or to Europe, but as we're learning in a global community, we have to think bigger. We have to think more collaboratively and more coordinated, because just because we're not there doesn't mean we won't eventually be affected. Ask the airplanes, all those airplanes. The U.S. Department of Health and Human Services, as I'm sure you know, we have regional Ebola treatment centers being established. I believe Sacred Heart is one of them. Is that correct? Okay. And that on July 1st, the Department of Health and Human Services launched a National Ebola Training and Education Center. And what I was really glad to see is that to prepare U.S. healthcare facilities for Ebola and other emerging threats. And that's really important. We need to be able to respond regardless of what the virus or the bacteria is. And we need to evaluate the national response planning and our surge capacity and our supply stockpiles. And that's ongoing at a national level. So reactions and responses must not be fear-based. How many people have done night shift? Okay. Some weird things happen at night shift because sometimes you have extra time. Okay. You can't rely on Batman. But one of our staff tried. So the other thing I wanted to mention, and I talk about the patients, and I talk about a community, and if you can't tell, I'm fairly passionate about that. But imagine lying there, dehydrated, losing fluids, you're weak, you can't eat. I was watching patients eat or drink out of a water bottle by the cap full only because they couldn't hardly swallow. And it's the middle of the night, and your team comes in to provide care. This is your view laying in the cot. I think that's really profound. Having somebody come up, you open your eyes, and this is what you see. And so if you keep that perspective of that patient as the provider and as a responder, we will all be that much more effective and that much more successful. So I wanted to just share something from our captain, the lead of our team. And he said, before accepting our assignments to Liberia, I let them know they would face danger, needed to accept certain risks, and that they would have to perform under extremely austere conditions. Turns out, if anything, I have underestimated that hardship. Initially, we lived 12 to a room in a 2-bedroom cabanas that were intended for 4 people, and we had septic issues, sewage backups, and overflowing toilets to boot. We had MREs intended for troops in combat, and 6 weeks into the 2-month deployment, we were moved into tents next to the mobile hospital, about 20 officers per tent. We worked 12-hour shifts in 90-degree heat and 90% humidity, often wearing head-to-toe heavy layers of plastic gear that left us soaked in sweat within minutes. A single slip in protocol could expose us to a deadly virus as we worked with vomiting patients who could defecate up to 3 gallons of diarrhea a day and could quickly dehydrate. So my question is, why did we do it? Why? This is why, right here. to see a healthcare provider overcome a disease that can kill you and be committed to going right back to the Ebola treatment unit and continuing to care for patients. Here's a few links that I have also related to this outbreak. Just a little wave goodbye when we were leaving. And here's my contact information. And I really appreciate your time. Thank you.